IJ, this is a new topic for all of you, and I try my best to make a brief conclusion at the end of the talk. And if anyone has any queries or question, please feel free to ask me after my presentation. So, declaration of the intentions. What is cancer care delivery system and what is our goal? So, understanding how healthcare system structures, processes, and available resources facilitate and the hinder the delivery of quality of cancer care is imperative, especially given the rapidly changing healthcare landscape. The emerging field of cancer care delivery research focuses on how organizational structures and processes, care delivery models, financing and reimbursement, health technologies, and the healthcare provider and patient knowledge, attitudes, and behavior influence cancer care quality, cost, and the access of ultimately the health outcomes and well-being of the patients and the survivors. In this presentation, I describe attributes of CCDR, that is the cancer care delivery research or cancer care delivery system, present examples of studies that illustrate those attributes and discuss the potential impact of CCDR in addressing disparities in care. So I conclude my emphasizing the need for collaborative research that links academic and community-based settings and serves simultaneously to accelerate the translation of CCDR results into practice. So the National Cancer Institute recently launched its community oncology research program, which includes a focus on this area of research, that is the cancer care delivery systems or cancer care delivery research. So at first, we have to know what is cancer. Cancer is another term of malignancy. So what is cancer? So cancer is a disease. We all know this is a disease. So in this disease, in which some of the body part cell grows uncontrollably and spread to the other parts of the body. Cancer can start almost anywhere in the human body, which is made up to the trillions of cells. The WHO says that the cancer is a generic term for a large group of disease that can affect any part of the body. Other terms used are malignant tumors or neoplasms. One defining features of cancer is rapid creation of abnormal cells that grow beyond their usual boundaries and which can then invade adjoining parts of the body and spread to other organs, which is called metastasis. So I share a video here. So here the cells are divided uncontrollably, and adjoining parts of the body they invade and spread to other organs. So widespread metastases are the primary cause of the death from cancer. And who shares some key facts about the cancer. Cancer is a leading cause of death worldwide, accounting for nearly 10 million deaths in 2020, or nearly 1 in 6 deaths. The most common cancers are breast cancer, lung cancer, colon cancer, and rectum cancer, and lastly the prostate cancers. Around one third of the deaths from cancer are due to tobacco use, high body mass index, alcohol consumption, low fruit and vegetable intake, and lack of physical activity. Cancer causing infections such as human papilloma virus, that is called HPV, hepatitis, are responsible for approximately 30% of cancer causes in low and lower middle income countries, that is the third world countries. Many cancer can be cured if detected early and treated effectively. So the goal of cancer treatment is to achieve a cure for your cancer, allowing you to live a normal lifespan. This may or may not be possible depending on your specific situations. It has been proven that health systems that focus on primary care delivery for cancer as opposed to specialist care produce better health outcomes or patients by improving access to care, upgrading continuity between patients and doctors, and reducing preventable mortality. Then coming to the next slide, what is the cancer care delivery system? This is our main focus in this presentation or this talk. So what is cancer care delivery system? The field of quality assessment in cancer care is relatively new, and investigators are just beginning to identify meaningful indicators of quality for many aspects of cancer care. So cancer care delivery research program, I say that the focus is on optimizing the quality of cancer care, cost effectiveness, and or of intervention that optimize patient-oriented outcomes, identifying barriers to quality of cancer care, and ensuring effective allocations of health and social resources. Health services researchers have used established indicators to determine whether outcomes of care are affected by how care is delivered or who delivers care. Several aspects of the healthcare delivery system have the potential to affect quality, that is the resources or capacity of facilities, example for volume of services, scope of services, access to technology, nurse staffing levels, academic affiliations, and the characteristics of healthcare providers and systems. Whereas in the defining quality care was confined to a review of literature on the breast and prostate cancer. This summary focuses on the way attributes of the healthcare system affect quality more generally, and thus include studies of other cancers. Many studies, for example, address the relationship between professional or institutional experiences as measured by the number of operations performed and outcome for individuals with cancer for which high risk surgery is indicated. Example, that is a pancreatic cancer. So in only the three areas was there a body of literature to examine, that is one, the effects of volume of cases handled by the hospitals or individual physicians on outcome; two, the effect of specialization of specialties or physician on outcome; three, the effects of managed care versus fee for service care on process and outcome. And a brief overview of this conduct of health services research and certain cautions about the inferences from such studies are warranted before individual studies in these areas are reviewed. So the number of cancer patients and survivors worldwide continues to grow as a result for our growing and aging population. I just mentioned in the previous slide. In 2013, an Institute of Medicine report detailed a crisis of the cancer care delivery system resulting in large numbers for cancer patients combined with increasingly complex treatments and rising costs associated with healthcare. Since the time, advances in genomics and the call for precision medicines have augmented these concerns, and our expenditure on cancer care have continued to rise. So multiple factors within the healthcare system impact the experience of the cancer patient and oncology provider. Cancer care delivery refers to the multiple layers of the healthcare system that interact to affect outcomes for patients and diagnosed with malignancies and the quality of that care. So coming to the next slide, I want to say here about the attributes of cancer care delivery system. So I believe the CCDR, that is the cancer care delivery research studies, are most likely to have the greatest impact on practice change if they encompasses one or more of five attributes. That is, here is I am defining here, that is one, the address problems just aligned to patients and clinicians; two, engage clinicians as active collaborators in the design and conduct of studies; three, use standardized measures of healthcare quality; four, examine casual pathways and the active ingredients of practice change; four, incorporate the diverse settings and samples. These attributes were identified through literature review and extensive discussion with CCDR experts. So this is all of this defining here. I collected this from cancer care delivery research, building of the evidence base to support practice change in community oncology. So those who are interested, please see this paper. This is available in the online. Then coming to the next slide, that is the a high quality cancer care delivery system. So what is this? What is the high quality cancer care delivery system? So in the United States, that is US, approximately 14 million people are cancer survivors, and more than 1.6 million people are newly diagnosed with cancer each year. That is the review from ACS 2013. By 2022, it is projected that there will be 18 million cancer survivors, and by 2030, 2.3 million people are expected to have newly diagnosed with the cancer each year. That also ACS defined in 2013. However, more than a decade after the Institute of Medicine (IOM) first addressed the quality of cancer care in the United States, the barrier to achieving excellent care for all cancer patients remain daunting. The growing demand for cancer care, combined with the complexity of the disease and its treatment and shrinking workforce and rising costs, constitute a crisis in cancer care delivery. So this is a diagram for that. So here is a domain for patient, then we need to interact with the clinician, that is the patient clinician interaction. Then the workforce happens, and then the evidence based to inform clinical care. So this is a loop. So the quality measurement, including patient outcomes and cost, are including here. Then the performance improvement and new payment models, and accessible, affordable, high quality care. So learning healthcare information technology system is defining in this high quality cancer care delivery system, which is the charting a new course for a system in crisis. So then the complexity of the cancer impedes the ability of clinicians, patients, and their families to formulate plans of care with the necessary speed, precision, and quality. As a result, decisions about the cancer care are often not evidence based. Many patients also do not receive adequate explanation of the treatment goals, and when a treatment phase concludes, they frequently do not know what treatments they have received, they have received the consequences of the treatments of the future health. They don't know everything. In addition, many patients do not receive palliative care for manage their cancer symptoms and the side effects from treatment. Most often, this occurs because the clinician lacks knowledge on how to provide this care, or how to make referrals or to palliative care consultants, or does not identify palliative care management as an important component of high quality cancer care. So complicating the situation further are the changing demographics in the United States that will place a new demands on the cancer care delivery system, with the number of adults older than 65 rapidly increasing. The population of those 65 years and older comprises the majority of patients who are diagnosed with the cancer and die for cancer, as well as the majority of cancer survivors. So to address the increasing challenges clinicians face in trying to deliver high quality cancer care delivery system, these reports a chart new course for cancer care. This is a great need for high quality evidence based strategies to guide cancer care and ensure efficient and effective use for scarce resources. So this is a book that is named Delivering High Quality Cancer Care. I am including this in the reference part. So please, who wants to know more about the high quality cancer care delivery system, please follow that. Then the importance for disseminating the evidence. What is the importance? So scientific knowledge achieves its highest value and best purpose when that knowledge is used to advance in human condition, right? So is the problem. Then the central goals of the healthy people 2010. This is the data from USDHH healthy report, healthy pupil 2010. This is published in Washington DC, January 2000, volume 1, page number 2. So the goal is to increase quality and years of healthy life and eliminate health disparities. Then what is the burden of cancer in US? US has the highest incident rate of cancer, a standardized, that is 362.2. Cancer is the leading cause of death of Americans under 85 years of age. Then coming to the next slide, burden of cancer in US. So 1 in 8 women in United States will develop breast cancer in her lifetime. There is a new to data, that is new cancer cases projected in 2004 is 1368030. This is a big amount of number, and the cancer dates projected in 2004 is 56700. So this is the matter. And also in India, cancer is one of the leading cause of death nowadays. So we need cancer care delivery systems. So now I want to show the cost of cancer treatment. This data I collected from Q-Centrics. So what is Q-Centrics? Q-Centrics CTR team spans more than 40 years of cancer data management experience. They unlock the value of your clinical data to realize your vision. So they projected the data that in 1963 the total yearly cancer treatment cost is 1.2 billion dollar. In 1972 that is 3.8 billion, in 1985 that is 18.1 billion, and 2002 that is 60.9 billion. So it increases day by day. Then nowadays this is the data of 2015, most recently data. So cost of prevalent and preventable cancers. So lungs cancer cost most, that is 282,000 dollar. In the breast cancer that is little bit less, and the bladder cancer and the skin cancer, that is the melanoma. So this is the data. Then what is cancer? A disease of process. So there is a cancer is a process from the birth to natural death. The lifespan is between birth and natural death. Cancer burden increases day by day, and there is some models, that is a prediction and prevention model, modulation model, and the treatment. So at first the thing is the prediction and prevention of cancer. So if the stage is not studies so at that time the prediction and prevention is did not happens, then it goes to the modulation, that is the pre-initiation, malignant transformation and evolution and progression. Then that also loss, then we have to go that the lethal phenotype, that is the cancer phenotype. So in the cancer there are many mutated phenotype. The phenotype is a result of mutation in genes that function in the maintenance of genomic stability. So it is manifested by the increase in mutation rates and genetic evolution of cancer cells that drives the tumor progression. So there are many such types of lethal phenotype genes that are APC, CRAS, BRAF, PIK3, CA, then TP53. That all are the lethal phenotype for cancer. At that time, if that also did not happen, then it goes to treatment. And if the treatment does not the treatment also loses, then the death due to the cancer, that is the before the natural death. So the death causes before the natural death, that is the death due to the cancer. So this is a disease cancer. Then I want to show a data from Agency for Healthcare Research and Quality. They shows that the cancer research takes 17 years to turn 14% of original research to the benefit for patient care. So at first what happens, the original research starts, that from that 18% gives the negative result. Then that is variable for different works, that is variable for this data, that is the 18% negative result. Then the submission process, the research submission process, that gives 46% negative result, that takes 0.5 years. Then then the acceptance method, then it takes 0.6 year. Then the publications have lack of numbers, that is the 35%, and it takes 0.3 years. Then the bibliographic databases, it takes 6 to 13 years. Then the review guidelines textbook, that takes 9.3 years. And then the implementation, so this total method takes 17 years to turn only 14% of original research to the benefit of the patient care. So this is the matter. So Agency for Healthcare Research and Quality gives this data on 2000. Then the NCI'S challenge close the gap between discovery and delivery. So NCI, that is the National Cancer Institute, gives it faces challenge. So there is a critical disconnect between research discovery and program delivery, and this disconnect is a key determinant of the unequal burden of cancer in our society. So barriers that prevent the benefits of research from reaching all the populations, particularly those who bear the greatest disease burden, must be identified and removed. So this is the NCI's challenge. Then the discovery and delivery continuum. So what is that? That is the three stages: discovery, development, and delivery. So at first there is discovery, then development means the basic science to translation and science. So what is that? So basic research or basic science research is a foundation of medical discovery. Through it we learn key information about the fundamental biological, molecular, and chemical process of life. Translational research, what is that? Translational research is a process of taking a discovery from the laboratory into a clinic where it can ultimately help people. So, so what is the matter then? Whereas basic science is looking at questions related how nature works, and translational research aims to take what's learned in basic research and apply in the development of the solution to medical problems. Clinical research then takes those solutions and studies them in the clinical trial. That is the delivery. The delivery refers the community health practice, primary care practice, and at last the oncology practice. So what is community health practice? We have to know that community health practice is a medical practice which focuses on people's well-being in a particular geographical area. This essential public health sector converts programs to help neighborhood members in protecting and improving their health, deter the transmission of infectious disease, and plan for natural disasters. The definition of public or community health nursing has two key components, that is one, promoting and preserving the health of populations, two, synthesis of knowledge from nursing and public health. These skills are acquired through graduate students and clinical experiences. Then the primary care practice, what is that? Primary healthcare addresses the majority of persons health needs throughout their lifetime, includes physical, mental and social well-being, and it is a pupil centered rather than disease centered. So primary care practice is pupil centered. And then the oncology practice, that is the last practice, that includes the main cancer care treatment practice. So this is the discovery delivery continuum. Coming to the next slide, that is the translational research versus research translation. What is that? We have to go discovery to development, so it's needed. So, what is that? The translational research, also called the translation research, is a translational science, or when in the context is clear, simply translation is a research aimed at translating or converting results in basic research into results that directly benefit humans. So the schematic outlines classifies the stages in the translational research in the next slide. So the translational research includes the three steps. That is one, developing treatments and interventions. Two, testing the efficacy and effectiveness of these treatment and interventions. And three, dissemination and implementation research for system-wide changes. Then the research translation. What is that? Research translation is the process of moving research ideas from lab to clinics. This is the main point. It ensures that new medical discoveries become part of the clinical practice of GPs, other specialists, and hospitals. We need research translation to move ideas in the two stages. What is that? From laboratory using human clinical trials. So there are some phases. The phase one is basic research, that research involving animal cells or tissues. Then the human research, this research involving living humans in carefully controlled setting. Then the phase two is translation from the practice and community-based research, and the phase three is use in everyday clinical practice. So this is the translational research and research translation. So we need that. So at first we need the academic cancer and medical centers for research, then the CCOPs and ACOS approved cancer programs we need, and then the resource limited municipal rural hospitals and clinics where we use these methods in everyday and everyday in the clinical practice. So this is the translation research and research translation. This is very important for the cancer care delivery system to uh, do the research practice partnership with the research practice partnership. So here in the next slide, I want to convey the partnership models. There is a state cancer plans, that is ACS, CDS, change, ACOS, ICC, NNA, CCR, LAF, and the collaborate with partners to support and expand the cancer control planet for community health practice. So I briefly describe the planet for community health practice in the next slide. So what is planet? So planet is a we can say planet is a page or planet something. So the full form of planet is plan, link, act, network with the evidence based tool. So what is that? So cancer control planet web portal was designed to ace access to data and evidence based resources for cancer control practitioners and researchers focused on developing, implementing and evaluating cancer control programs. So what is its objective? This planet's objective to determine usability, applicability, and opportunities to improve the Planet Web portal after significant changes to the portal over time. So, who designed this? So, National Cancer Institute (NCI) surveyed and interviewed cancer control professionals to access factors influencing utilization of Planet data were collected May 2017 to June 2018 via partner agencies, electronic publications, and online links. Then, what are the outcome? So and their measurements. So descriptive statistics with chi-square test were used to analyze the quantitative data and examine the relationship among variables. Qualitative interviews further informed the quantitative analysis. So what is the result? The result is more important because of the 724 participants surveyed, that 51% were users of Planet with the majority accessing Planet within the last 6 months. Most users felt Planet effectively met their needs for accessing specific cancer data, identifying evidence-based programs and asserting details on the various cancer topic. There were statistically significant differences in the demographic characteristics between users and non-users of Planet, where users were more likely to have more experience in the cancer field, were older ages and located in southern states in the US. So they conclude that the NCI conclude that the result indicate that Planet is seen is a variable and credible source of cancer control program planning and delivery. A reassessment of Planet's goals is warranted, which may support reaching out the new audience, amplifying or removing underutilized resources, and adding additional resources and topics. Consideration for training and tutorials on Planet would benefit partner agencies and build capacity for evidence-based program development. So there are 5 states. What is that? The step one is access the program priorities. There is a state cancer priorities, CDC and NCI. Then step two is identify potential partners. Then step three is determine effectiveness of different intervention and approaches. Step four is find research tested programs and products. And step five is plan and evaluate your program. So there are more information for cancer control topic is a breast cancer, cervical cancer, diet, nutrition, nutrition for 5 a day, physical activity, sun safety, yoga control. That is all in the Planet. So here is the link. You can see there. Then how to use this website. So find research tested invention program and products. We can search here, review summary information and usefulness integrity scores for each program we can find there, and order and download materials to adapt for use in our own program. So this is the method. So here is some program topics. There is a breast cancer screening promotion, cervical cancer screening promotion, diet, nutrition, physical activity, sunset, tobacco control, all is here. So then the development of clinical Planet. So you have to, here is a link, cancer information and handouts. This is a handout, and then a referral resources, then the link for clinical guidelines for prevention and screening, and the clinical software and tools. So this is all about the Planet. Then the screening implementation is complicated. Why? So what is the process of care? At first we have to do the risk assessment with respect to age, family background or history, exposure, then genetics and lifestyle. Then the detection screening, that is the CBE, mammography, that is affected for the breast cancer, pelvic or PAP, FOBT, and sigmoidoscopy. Then the diagnosis. How to do that? That is a mammography, ultrasound, biopsy, repeat exams. All we do for the cancer diagnosis. Then the treatment, surgery, radiation, adjuvant chemo, palliative care. So then if the potential, these 4 steps are failed, then the morbidity, mortality, quality of life inspection, and the quality of death. That is the whole process of screening implementation. So this is complicated, too much complicated. We need every step, and we don't have to fail these steps. And if that is happen, then the morbidity happens, and the quality of life satisfaction and the quality of death is too much pathetic. So the system change is critical. Why? The systematic implementation of evidence-based medicine, that is for the guidelines are necessary but not sufficient. The IOM report, I have told in the previous slide, the IOM report that the systematic change is needed, and the chronic care model. This is important. The chronic care model is too much important. I show here in the next slide. Then the organizing chaos for change. We need to change the organizing chaos, this chaos. So that is the conceptual organization and the chronic care model. So what is chronic care model? So chronic care model is a model designed to help practices improve patients' health outcomes by changing the routine delivery of ambulatory care through 6 interrelated system changes meant to make patient-centered, evidence-based care easier to accomplish. What are that? The 6 steps. That is the community resource and policies, health system, self-management support, delivery system design, decision support, clinical information system. So there is a outcome. What is that? The prepared protective practice team and the informed activated patient. That is a productive interaction. If we do it positively, then the improved outcomes happen. So this is the chronic care model. Then moving science into oncology practice, the FDA, that is the Food and Drug Administration collaboration do this, and Centers for Medicine and Medicated Services (CMS) collaboration do this. Then we have been taking about the dissemination for quite a long time. When the NCI was first authorized in 1937, the Congress mandated that NCI promote the useful application of research results. The cancer control sections of the National Cancer Act of 1970 was designed to ensure more rapid and effective communication of research results to medical practitioners and as appropriate to the general public. This happens here. And then I want to conclude this. So I want to say that, and this is a take home message also, so that the changes across the board urgently are needed to improve the quality of cancer care. All participants and stakeholders, including cancer care teams, patients and their family, researchers, quality matrices, developers, and the payers, and as well as the HHS, that is the United States Department of Health and Human Service, other federal agencies and industry must re-evaluate their current roles and responsibilities in cancer care and work together to develop a high-quality cancer care delivery systems. By working towards this shared the goal, and the cancer care community can improve the quality of life and outcomes for people facing diagnosis. And this is the one more thing, that in India, cancer care delivery at the grassroots level, we have to improve the outcomes also. So the cancer care system, the cancer care delivery system is more important, and we have to improve the quality of life and outcomes for people facing cancer diagnosis. So I share the references here. There's the first reference, delivering high quality cancer care, that is written by these authors, and second one, that is including the evidence based support of practice change in community oncology. The third is the anatomy and physiology of teaming the cancer care delivery, a conceptual framework. And the fourth is this is the IOM report, which I have told in the previous slides. So this is all about my talk today. Thank you.